Okay, so I hope you're all back from the break and now you have all the energy to wrap up the dermatology, and we have to discuss the questions. All I've taken the last 3 years PYQ for you to discuss, and I hope that you'll find them very easy to solve. So let's put all our energy into the session now. So vesiculobullous disorder. Last topic, but Vishnu, low energy. Let's just gain some energy because the last few minutes, I would say. So let's do it all together. Okay, so vesiculobullous disorders, we have immunobullous variant where we have intraepidermal, in which we have the pemphigus group of disorder, and it can also divided on the basis of split level of split into the subepidermal, where we have the pemphigoid, dermatitis herpetiformis, and chronic bullous disease of childhood. Whereas in the mechanobullous disorder, we have a condition called as epidermolysis bullosa. So they have been asked previously, and let us now discuss. So when we are talking about vesiculobullous diseases, what are the kind of lesions which are present? So there is a vesicle which is less than 1 centimeter in size, fluid filled lesion it is, and then we have a bulla which is more than 1 centimeter in size, and this is the bulla which is there. So these two lesions will be seen in these disorders. Now let's talk about the pemphigus one. Okay, so what is the level of pemphigus? So as you can see, pemphigus, the P word can remind you the intraepidermal bulla. So this is targeting your desmosomes. Desmosomes, I hope you remember the cell-to-cell connections between the keratinocytes. Okay, intraepidermal intercellular connections. Fine. So in this, we have the target protein, as I said, is the desmosome. So they can be of two types: the foliaceous type and the vulgaris type. So first thing you have to understand is that whenever the question comes, you should be able to do the differential diagnosis between the two conditions. Fine. The foliaceous variant has I in it. I or F can remind you the first one. So what is this first? The desmoglein 1. So the antibodies are there in against desmoglein 1, which is going to produce a subcorneal bulla. Okay. So this is having a very thin roof. The bulla is having a very thin roof. So again, foliaceous first and so against desmoglein 1. So the clinical feature, this is transient, the bulla is superficial, and it can rupture immediately. So if it ruptures, what is going to be happening in the patient? Scales and crust will be seen. As you can see, there is crusting and scaling which you can see. And I told you this, I hope you remember that M, you just rotate M and it becomes 3. So the desmoglein 3 is involved into the mucosa. Okay, but here we saw that in first one, the desmoglein which is involved is desmoglein 1. So that is why there is no mucosal involvement. Sorry, no mucosal involvement in them, which you will see. So that is important for you to diagnose foliaceous. Whereas when we'll move to the vulgaris part, we'll see that desmoglein 3 antigen will be involved. Okay. So vulgaris, there is IgG antibody against desmoglein 3, I said, whereas in the foliaceous variant, we had just desmoglein 1 against antibodies against desmoglein 1. So this is a suprabasal bulla. It is a flaccid bulla, and the age of the patient of presentation will be 40 to 60 years almost. As I said, 3 for mucosal involvement. So there will be 90 to 95% patients with the oral lesions in pemphigus vulgaris group of disorder. As you can see this, and has this Nikolsky sign. When you put a pressure on the bulla, then it gets split like that. Okay, and I'm just taking the important points here. Very, very important is the investigation of choice. This has been given in exam as an image based question previously, which is showing you if you can see this, like this is a fish net appearance. Very important, again, has been asked. Fish net fishnet appearance. Then again, what is happening? There is a suprabasal split which you can see, and there is acantholytic cells which you can see. Okay, and there is a row of Tom appearance which you can compare. So these are the keywords for Pemphigus vulgaris. Vulgaris again is foliaceous, doesn't involve mucosa, definitely. Jyoti, you're absolutely right. So that is the takeaway for this foliaceous. There will be desmoglein 1 because first, and in this there is type desmoglein 3 which is involved in the vulgaris type. Then in the subepidermal blistering disorder, we have bullous pemphigoid to discuss, where the antibodies are formed against the hemidesmosomes, which we saw in the basement membrane zone. Okay, the antigens which are involved are these, and what happens is there is an activation of complement system which leads to eosinophil recruitment and release of proteolytic enzymes which breaks your basement membrane zone. So because this is under the this is the area the basement membrane zone is involved, that is why the bulla is subepidermal and the roof is thick in them, whereas in the pemphigus vulgaris and foliaceous there was thin roof. Okay, the clinical features, the age of presentation is 60 to 80 years in bullous pemphigoid. Okay, and the dense bulla is there with erythematous, so you can see there is pinkish reddish appearance, so there is a tense bulla. So this is very tense bulla which is having erythematous red base, and they have they can have this erosions which you can see. Where is it present? On the lower extremities, trunk and abdomen. Nikolsky sign is negative in this. Bulla spread sign is there, and round and regular margins of the bulla which you can see. Fine, then the Tzanck smear on this, you can see eosinophils. You can appreciate histopathological image. Most importantly is this your direct immunofluorescence image which shows your linear pattern. Okay, so this is treatment, you give low dose steroids. That is all. So I would suggest you to go for the direct immunofluorescence image in both of the conditions, and then the where it is involved. Then let's move to the dermatitis herpetiformis. So this has pruritus. That is important for you to understand. IgA antibody is against epidermal transglutaminase 3. This is associated with HLA DQ2, DQ8, and B8, HLA B8. This is important. And systemic diseases, this is associated with celiac sprue, very important condition, and gluten, which is your gluten sensitive enteropathy. So patient is just sensitive to the gluten. So that's what we take care of in their diet. We give them a gluten-free diet. And what is to be given? Avoid bro. What is bro? Barley, rye, oats, and wheat. Okay, best test for celiac disease overall, you should be able to, you should know this. Tissue transglutaminase IgA antibody. That is the test which you give to them. So this is skin lesion which you can see. And I would say the more important is this granular appearance of the direct immunofluorescence, which is seen. So you should be able to distinguish between this immunofluorescence images of all the conditions. That is going to fetch you the answer. If you read everything, then you will not be able to actually do the differential. Then the chronic bullous disease of childhood, there is an autoantibody against A. So, childhood disease, it is a childhood disease. So during childhood, we learn these ABCs. So the IgA antibody is involved. I hope that can help you to remember this. So there is a subepidermal level split, which is there. And this is the classical finding which you can see. The cluster of jewels, like as if the pearls are arranged like this in the annular arrangement. Okay. Treatment, what do you give for treatment? The depth zone, which you won't be asked probably. Most of the times they ask you an image-based question. More if you want to remember that, remember IgA. Then the genodermatosis let's move towards the end of the lecture. Neurofibromatosis is the one which we have to read. Neurofibromatosis type 1, which is also called as von Rechtlichen-House syndrome. So this is an autosomal dominant disorder. Okay, so what kind of different conditions which are there? We have a cutaneous neurofibromas which are present. So you can see there are a lot of neurofibromas. Nodular lesions are present in this type. So papulonodules are present. This is benign. It does look like a tumor, but it is not a tumor. Okay, it's benign condition. And about plexiform neurofibromas, we can see as if there is a bag of worm which is there. It is congenital. Very important is your cafe au lait macules. More than or equal to 6 cafe au lait spots should be there. Okay, so in prepubertal age, it is more than 5 mm in size, and in postpubertal, it is more 15 mm in size. So that is used for diagnosis. Then we have axillary freckling. Just you have to see that in the axilla, if you remember that hyperpigmented disorder, the freckles. So there is freckles present here in the area of the axilla, but I don't think so that they'll be asking you this question. And then there is this leash iris nodules. Just remember the image and just move ahead. Okay, then we have your tuberous sclerosis complex, also called as Bonville's disease. Remember the Vox triad for that? We have epilepsy, low IQ, and adenoma sebaceum. This is the ash leaf macule, which is classical for tuberous sclerosis. That's one thing which you have to remember. Then we have, like on the sebaceous areas of the face, we have adenoma sebaceum. This is how it is seen. And then there is, you can see periungual fibromas, which can be seen. And another classical feature of tuberous sclerosis is shagreen patch, which can be seen. Let's now move to another condition now, the Sturge-Weber syndrome, which is sporadic in nature. And the triad of Sturge-Weber syndrome is epilepsy is there, glaucoma is there, and there is a port wine stain. It does appear like a wine. The color is a wine color. That's why it is port wine stain. So this image will come to you in exam for Sturge-Weber syndrome. Treatment, you give a pulse dye laser. They'll not ask you. Ichthyosis. So word ichthyosis means fish-like. Okay, so we have most common ichthyosis vulgaris, which is an autosomal condition. So because of the dryness, what happens is fish-like scaling of skin, which is happening. And there is this X-linked ichthyosis as well, which is Nigra type. And what happens is this is more severe. In ichthyosis vulgaris, we can see filagrant defect. If you remember, we just discussed this in the keratohyalin granules, where we saw keratin intermediate filaments, right? So this is a filagrant defect, and this is steroid sulfatase defect. So basically, this is just a dry. If you commonly you want to just understand in one word, the skin is getting so dry. Lamellar ichthyosis is another, which is a colloid membrane. So this baby, just they'll give you most of the times image-based questions for the same. Okay, and then we move for the important disorder, which is your xeroderma pigmentosus. Look for photosensitivity. That is very, very important for xeroderma pigmentosum. Okay, so this is what it is, a nucleotide excision repair defect. Very, very important. Patient will have photophobia, xeroderma, and freckles, and it is a condition which increases also the risk of skin cancers. Okay, important is to remember the nucleotide excision repair defect. Then we move to the connective tissue disorders. Acute cutaneous lupus erythematosus, there is a butterfly rash. I would just ask you to, just stick to the keywords right now. Butterfly rash, you can see because it appears like a butterfly. Okay, the two wings which is there on the malar area. And very important is this, in this condition, the nasolabial folds are spared. So if you can see this nasolabial folds, they are not involved. That's important. Okay, so photosensitivity is always there in this as well. Then we have chronic cutaneous type, the discoid one. We can see there is a discoid plaque which is there. And atrophy and scarring is there. In the periphery of this lesion, of this discoid plaque, you can see hyperpigmentation is there. Okay, this is one thing which is classical for this. Remember C for D, CD, a discoid plaque is present in this chronic cutaneous lupus erythematosus type. Okay, then we have dermatomyositis, proximal myopathy. So the word here is suggesting you myo is for muscles. Okay, so there are skin changes, but of course we are reading dermatomyositis. So there is myopathy, there are skin changes as well. Okay, so very classical of them is your Gotran's papules, which is violaceous flat top papules present on the knuckles of the hand. And there is heliotrope rash which is present in them. That is something which you have to remember. Then systemic sclerosis. Okay, I would suggest you not to read it because they won't be asking you this. Systemic sclerosis, they have crust syndrome. Okay, and the facial features, you just focus on them. They have a mask like faces, a pinched nose, perioral furrows will be there, and microstomia will be there. Then we have Henoch-Schönlein purpura. This is a small vessel vasculitis. You also study it in pathology, so I'm just taking it a very quick review only. It is IgA based, and there is palpable purpura in them. This is a symmetrical condition, and both the lower limbs it is present, and that is all you need to know about. So next, let's move to reactive arthritis now. I hope you can just push the session little more. Okay, just be alert. I know it's getting late, but just a little bit of things are left. Okay, reactive arthritis, the inflammatory arthritis, which is secondary to some distant focus of infection. That's what you need to know. That would be enough for it. Then we have erythema nodosum. Okay, here we can see that there are red. Okay, this you can see this is red and tender nodules which are present on the anterior surface of leg. So this nodosum is going to remind you of the nodules, and erythema is going to remind you of red. And red, why this is red? Because it is tender. So red tender nodules over the leg, nodosum, erythema nodosum. Then we have a Lofgren syndrome, which is the feature of acute sarcoidosis. Okay, but there is bilateral hilar lymphadenopathy which is present in them with arthritis and fever. So this is the condition of Lofgren syndrome. Then we have acanthosis nigricans, and I hope that everyone is aware of this. There is nigricans. There is a velvety plaque which is present over the nape of the neck. There is dark, blackish discoloration, hyperpigmented velvety plaques which can be seen associated with, look for history of diabetes or PCOD probably, and obesity being one of the more common cause. So in axilla and neck folds you can see this. Then we have a granuloma annular, which is also again associated with diabetes, and it has annular papules. So you can see again annular kind of a lesion, and it is present on the dorsum of extremities again. Then this name itself again telling you that it is associated with diabetes, necrobiosis, lipotica, typeticorum. So these the conditions which we are reading right now are less important. That's why I'm just taking it a little quicker. Okay, so this is associated with diabetes, has waxy yellow plaque with telangiectasia. So you can see the dilated vessels over here, and anterior leg is involved. Then we have pre-tibial myxedema. The more important for it is association. So it is associated with Graves' disease. So obviously you studied in medicine as well. So this is diffuse non-pitting edema can be seen, and it is also present on the anterior surface of leg. Then we have another condition which is happening because of some nutritional disorder. So you study with in conjunction with biochemistry this one, phrynoderma. So you can see hyperkeratotic. So children come to OPDs with this condition, and because of the vitamin A deficiency, their follicles they become hyperkeratotic. Okay, so this condition is also associated with maize, Zawarish diets, and chronic alcoholism. Again, is one more condition. And pellagra, this Cazals necklace, I believe that most of you have been aware of this. Very important. This is happening in the niacin deficiency, which is your vitamin B3, and the triad of this is dementia, dermatitis, and diarrhea. That kind of a severe diarrhea, that patient might end up with the fourth D, which is death because of that. Okay. Then we have xanthelasma palpebrum. So the name itself is telling you xanthal is this word is suggesting you this yellow kind of deposition. So lipid. So this is often a condition when people come with this. This is more of a cosmetic kind of a disfigurement in the patient which is happening. So because of the hyperlipidemia, people develop this yellow kind of a nodule on the papule on the eyelid. Okay, so that is all about this. Then we have some another miscellaneous topics to finish off with. The mycosis fungoides. Okay, this is cutaneous T cell lymphoma, and the Sézary syndrome, which you can see, and the basal cell carcinoma. So basal cell carcinoma is a rodent ulcer. So you better actually just revise this with the image, this kind of image, because the image has been asked. Most of the other things have been not asked and won't be really asked. So I would just skip this because these are very less important for you. Then again comes the very, very important topic, because this has been asked at least more than 2 times, the fixed drug eruption. So that is the area which I would like you to focus. Now, the name, the cutaneous adverse drug reaction. So when we are studying this, of course, this is a skin condition, and why it is happening because of some drug which you have taken, patient might have taken, and some reaction has developed to that drug intake. So drugs which are often implicated in this, NSAIDs, cotrimoxazole, or tetracyclines. What happens is, why this is named as fixed drug eruption? Because this lesion is occurring at a fixed same site and the re-intake of same medicine. So the patient probably will say, I took ibuprofen on some day and then I got this kind of a lesion, and he's coming with the same set of lesion. And this is a hyperpigmentation, which like it heals with the hyperpigmentation, which you can see. And this is classical. So the history is more important for FDE. So you look for history and you forget about appearance of the lesion. That is going to make sure diagnosis clear. Then the erythema multiforme, it is cytotoxic dermatitis. What happens here is multiple symmetrical lesions are there on distal extremities. So this also called as target lesion, and the trigger is for this is HSV infection. Okay, so center is dusky, then there is a pallor, and then there is again dusky part. Okay, so that is the erythema multiforme. That is all you need to know. Then we move to Steven-Johnson syndrome and toxic epidermal necrolysis. So this mucosal involvement, we saw the lentigenes and everything. I hope you remember, right? Anyone who remembers this? Are you people able to make up with the pace of the class? So let us move to the more important condition right now. Okay, dermatological investigation. I had discussed. Okay, Shankar, just they were less important things. That's why I went a little faster. So diascopy is one of the investigation which can be done, which where we just put a glass slide and we press over the lesion. That can give a blanching response. If there is a blanching response, okay, then if there is erythema which is like just going away, then like if it is still there was a red thing and then we pressed with the glass slide and it is still there, the erythema is still there, then it is a blanching. And then there is non-blanching response where the staining still stays. Why there is still a staining? Because RBC, they extravasate. So they comes into the vessel and they stain the vessel. So even if you press, the red color stays. Okay, that's happening in the purpura or the petechial rashes. For example, if dengue is there, so there will be purpural rashes. So when you press it with a glass slide, then you will still see the red color. Then apple jelly nodules. Where did we read it? Just repeat it with just comment down in the comment section. So this is a yellow brown color. Like when you push, like if this was the apple jelly nodule, you pressed it with a glass slide, you did a diascopy, and then you see that there was a color change, which was a yellow brown color. And it is a feature of dermal granulomas, which can be seen in lupus vulgaris, sarcoidosis, or cutaneous leishmaniasis. Last, which we have to know, is wood lamps examination. This is a wood lamp. Sometimes they can just give you an image and ask, what is this? It is a wood lamp. This examination, basically this skin is examined under UV light, and the wavelength for it is 365 nanometer. Okay, then filters which are used are barium silicate and 9% nickel oxide. Probably they'll just probably ask you the image. And this is important. Apart from image, they can ask you erythrasma. We have already done it. There is a coral red color, when on wood slump examination, there is a coral red fluorescence which can be seen. And in Pityriasis versicolor, there is a yellow fluorescence which is seen. And in Microsporum species, this is blue-green, whereas in Trichophyton schonleni, it is dull blue. And in vitiligo, the depigmented disorder, so everything is going to turn chalky white. So the wood slump examination is also going to be milky white in color. Then some phototherapies. Again, we had already discussed the UV rays thing, but in addition to that normal UV rays, we can also use a PUVA therapy. What is PUVA? It is having psoralen, which is a photosensitizer. So when you give psoralen, the capacity to take the UV rays gets increased, because it gets the skin gets sensitized to it. Okay, then indications of this is psoriasis, vitiligo, and atopic dermatitis. So phototherapy can be used in psoriasis, vitiligo, and atopic dermatitis. Again, this is a repeat, so I'm just taking it a little quick. Then we can have a cryotherapy in dermatology, where liquid nitrogen can be used, where for what specifically it is indicated. I would suggest you to focus on wood slump examination as well. So I hope you're ready for the question. All of you are ready for the questions? See, I would suggest you to go with the question part more. Okay, because I want all of you to be little more attentive right now, because we are going to just start with the questions, and you are going to answer me the questions. So a 50-year-old female patient who is a known case of ovarian cancer presents with difficulty in activities like climbing stairs, getting up from the chair, combing her hair, and the characteristic sign was seen. What is this sign, and what is the most probable diagnosis? Yes, I'm waiting for your answers. I have got a couple of answers, and absolutely the dermatomyositis, as we discussed, there is muscle involvement as well. And can anyone tell me the sign which is shown here? Absolutely right, Bhuvan, the heliotrope rash. Then let's move to the next question. A baby presents to the OPD with the following finding. What is the probable diagnosis? Is it a port wine stain? Is it a cavernous hemangioma? Is it a nevus complex and or is it a capillary hemangioma? So I told you that in dermatology, most of the times there will be questions related to most of the images. It's a capillary hemangioma. Okay. So I hope that you all are going to go back and revise one more time. That is going to be sufficient. 18-year-old female comes with this finding. Which of the following is the pathognomic of the primary stage of this disease? Is it papule, pustule, abscess, or comedon? Abscess, it doesn't look like an abscess. Absolutely not. So as you can see, this is the grade 1 acne, and is it open, closed comedon? Okay, so this the answer for this is D, the closed comedon. Next, we see is a 26-year-old male presented with erythematous plaques covering with silvery scale is the takeaway. And you should already have the answers. And then extensor surface. The question has already told you everything. Punctate pitting was noted on examining the nails. What is the most likely diagnosis? So everyone is good. I hope the questions which are coming in exams are very easy, so you can just be sufficient with the this information is sufficient for you to solve the questions. Then a patient presented with, so yeah, psoriasis, everyone is right. Psoriasis is the answer. Then we have this, a patient presented with itchy lesions as shown below. What is the most likely diagnosis? Is it scabies? Is it lichen planus? Just don't mark scabies if there is itching. Is it lichen planus? Warts? Absolutely no, I guess. So again, frame, just because you can see itchy, you have to look for special burrows for scabies. Most of the time, they are going to give you the web spaces image if they want to ask you scabies. So the answer for this is, remember something, the 6 P's. Yes, Bhuvan, absolutely. The polygonal, pruritic, flat. Okay, polygonal type. This is lichen planus. Okay, then the FMG July 23 questions. Patient presents with hypopigmented lesion on his back. Okay, uh, just consider this back. On examination, there is a complete loss of fine touch. Again, the complete loss of fine touch is a giveaway for this question, because that's what we discussed. Hyperpigmented lesions can be there in so many other conditions, but the loss of fine touch won't be there, and temperature sensation over the lesion. What is the most likely diagnosis? Is it psoriasis? It is Hansen's, leishmaniasis, dermatitis. Yes, as I said, the takeaway for this is cross border vlogger, absolutely right, because there is a loss of fine touch and temperature sensation. This is very, very specific and classical for the Hansen's disease. Then we move ahead with female patient presented with the lesion as shown below. What is the most likely diagnosis? Is it a squamous cell carcinoma, basal cell carcinoma, malignant nevus? For sure, cross border, you're absolutely right. So, this is a malignant melanoma. All of you are well aware. So, I told you when we discussed this image, I told you that it has been asked previously, but you can't, you know, mix it. So don't confuse this image. Just they gave the image and asked the condition. So is it looking cauliflower in appearance? Because everyone is saying condyloma lata, acuminata. So many are saying acuminata. Is it actually looking like a cauliflower? So this is somewhere, this is a place where you need to focus a little bit. Okay, they haven't given any history, and that is like kind of very confusing. Someone is saying hemorrhoids, so actually this is hemorrhoids, because in acuminata I said there will be pointed lesions of, and then later on they'll be converted to cauliflower like lesions, which is not this case. So they were something like this kind of a condition. And latta was like flat lesions. I told you latta is like lata, that like sleeping. Herpes genitalis is absolutely not, because there are vesicles which are characteristic for this, but this is a hemorrhoid. Okay, that's what is to be asked. But I believe that they will give you some hint, of course, not just the image will be given. Then I believe all of you can be are able to answer. Female who presented a few weeks ago to the OPD with an itchy skin rash. She was prescribed a topical ointment which relieved the itching. However, after a few days of stopping the ointment application, she presented again with the same complete complaints. What it could be? So everyone is giving the right answer. This is tinea incognito. I said to you that when you want to make a diagnosis of tinea incognito, just look for the history of some topical steroid usage. Okay, that's what is the takeaway for your tinea incognito. Then let us move towards the next question. A patient presented with joint pain which increases in the early morning. So early morning stiffness is characteristic of when he wakes up and it decreases with activity. After some time, this gets better. So everyone is answering. Examination reveals the following picture along with the inflammation of the wrist. Okay. So this is a case of psoriatic arthritis. We already discussed it today. So this is a case of psoriatic arthritis. Just go back and revise one more time your session. 60-year-old female patient presented with purplish, itchy, flat top lesions on her shins for the past 3 months. Okay, just these are the things which you should think of. The patient also gives a history of chewing tobacco for 20 years. She occasionally drinks alcohol and smokes. On examination, the lesions are seen. The image quality, I believe that it's not good enough for you, but try to make a diagnosis. On examination, the lesions are seen as in the image. What is the first line of management for this condition? Have this inguinal bubo is characterized by which of the following organism? I believe that you can answer at least this. Already, you all are answering really great. So look for the painful bubo. Okay, someone is gonna cry. Bajay Priest 12, Beige Priest 12. I don't know what your name is, how it has to be pronounced correctly. But yes, you are right. It's Hemophilus ducreyi. I said ducreyi and two times ducreyi, okay, because there's a painful bubo also which is there. Then the next question is, a young woman was suspected to have bacterial vaginosis. Which of the following statement is false about this condition? Okay, one is Gardnerella vaginalis is the causative agent. Second is the Amsel's criteria is used for diagnosis. Then vaginal itching is prominent. Oral metronidazole is given for the treatment. Did I tell you? Okay, someone is saying A. Someone has come up with the right answer. A couple of you have come up with the right answer. Bhuvan, you're absolutely right. So, as Bhuvan said very correctly and precisely, vaginal itching, prominent, very intense itching is a feature of vaginal thrush, rather. Okay, so that is the correct answer. Others are the answer for bacterial vaginosis. Okay, then This all of you have seen, right? Wood lamps examination, this coral reef, red reef appearance. What is it? Erythrasma, absolutely. So, this was a very easy question. Which of the following is seen on the microscopy in the lichen planus patient? I told you that in dermatology they just asked you very, very easy questions. So you give 2 hours to dermatology for your last revision. You're just good for the exam. That's all. Bhuvan, it's right. It's colloid bodies. Okay, that's right. Then we have a 6-year-old child with a sore throat. Okay, so look for sore throat, some infection history. Which of the following is the most likely type of psoriasis which is present in this patient? I told you there will be some infection which will be there, and then there will be some, you know. So what is this? Is it guttate? Is it erythrodermic? Is it pustular or is it inverse? Kunal, Kunal is absolutely right. Pranay is absolutely right. Viraj is absolutely right. Okay, so see, I told you there itself that there will be some history of some infection which will be given. So it is a guttate psoriasis where we saw raindrop kind of lesions. Okay, so this is a guttate psoriasis. Then an 8-year-old child, moving to the next question, was evaluated for multiple skin tumors. The workup revealed defected nucleotide excision repair defect. Very, very important, and this is mostly associated with the photosensitivity. So this is a very important disorder. Everybody is saying the right answer, xeroderma pigmentosum, is very, very right. Absolutely right. Then you have a 10-year-old boy who is presenting with complaints of nocturnal pruritus. Now, those who have been saying for general itching, scabies, think of it. There is a nocturnal pruritus which is there. Examination shows burrows over intertriginous areas, axilla. They have a circle of Hebra is all written here in the umbilicus and between the digits, the web spaces. Who's saying exodistic? When did I teach you that? Which of the following is responsible? Burrow is important, absolutely. I want more answers. Yes, it is scabies, absolutely right. We can see that it is scabies. So, scabies is caused by sarcoptes. Okay. Then we have next, which is who is a 38-year-old female, started on OCPs. She was referred to the dermatology OPD with hyperpigmentation on the macules, on the upper lip, and the malar region. Okay, so there is some case of pregnancy, but otherwise it is melasma. Okay. Then we have a 21-year-old female presented to the OPD with complaints of recurrent lesions on her lips like this. Okay. Which of the following characteristic feature is seen on the Tzanck smear? Future doctor, v HSV1 cold sores. Okay, but what is the, it's multi-nucleated giant cell. Okay, then we come up with this last set of questions. The FMGE Jan 25, a 50-year-old lady, she got diagnosed with breast carcinoma, who underwent chemotherapy, presents with hair loss after 3 weeks. So very initially, we just discussed that there were different kinds of effluvium which were happening. So she has breast cancer and she is undergoing chemotherapy. So this is associated with, so many people have already come up with the answer which is right. So C, it is happening in cancer. CA. Okay. So it is happening in cancer, CA, because of chemotherapy. So A is for anagen effluvium. So where diagnosis? Is it A, B, C, or D? Is it Grattage test, Nikolsky test, Asboe-Hansen test, or patch test? Anagen effluvium was the answer for the question which we just did. I'm waiting for your response for this last question. Nikolsky test, no. I told you the scraping thing, if you remember. The answer to this question is the Grattage test. Okay. That's what you need to remember. Then we have a 4-month old child. The next question, who was brought to hospital with an abdominal lesion. So this is a kind of a lesion which is present. And what you will just do with this lesion? Would you like to just observe and wait? Would you like to do the surgical excision or triamcinolone or betaxolol? Someone is very eager to just excise the lesion of a baby. Okay, some of you, yes, priest 12, you're absolutely right. Yes, so the answer is observation. You just need to observe. That's all what you need to do with this. And I told you very important topic of dermatology. They have asked you 2 to 3 times, okay, in last 3 years. A patient presented with multiple nodulocystic. They have given already what kind of a lesion it is, nodulocystic lesion on the face. Okay, even if the image is not clear, then also you can crack this question. Which among the following is the drug of choice in this condition? Everyone is right. Isotretinoin. It is a case of nodulocystic lesion is a grade 4 acne, and the answer to this is isotretinoin. Then we have a 30-year-old female who presents with painful genital ulcers on vulva accompanied by bilateral lymphadenopathy. Okay, so painful genital ulcers, bilateral lymphadenopathy, history of multiple partners over the years. What is the diagnosis? Most of you are giving the right answers only. It is chancroid. Okay, just if you can't recollect the information, you just need to go revise your dermatology RR today's session just one more time. And this last, the given picture shows the lesions which are found on the glans planus, and there is pigmentation in the chin and the oral cavity as well. So this is, this kind of condition is seen in lichen sclerosis. You don't see any fissures and all. Today's session would be enough for FMG if you revise it at least twice. Like you just have to flip through the pages. That will be enough. Okay, a full term neonate who was delivered by an uncomplicated vaginal birth is noted to have bulla and abrasions over the shoulder, knees, and legs shortly after delivery. What is most likely diagnosis? Is it erythema, epidermolysis bullosa, pustular melanosis, and erythema toxicum? So most of the conditions we have already covered in the session. If anything is left, you just have to pop it with your previous year questions, because they take up the previous year topics only, and that's what they ask. So it is epidermolysis bullosa. Okay. We just move to the next question now. Most of you are already answering good. A 6-year-old girl who's presented with multiple small skin colored papules. Now, this they have already given you the whole features of this particular lesion, which I've told you. I've repeatedly said you focus on this central umbilication over the trunk and face. This is present. So in kids, it is mostly present on the trunk and face, whereas in adults it is present in the anogenital area. So it is molluscum contagiosum. Okay. Then we have a 20-year-old dentist who is presented with painful groove vesicular lesions on the distal phalanx of her right index fingers. She reports a burning sensation followed by the appearance of fluid filled blisters that ruptured into shallow ulcers. She denies any systemic symptoms. Which of the following is the most likely condition? Very, very commonly asked. Even you study it in your microbiology, herpetic whitlow. So everyone is already giving the right answers. Then we have which of the following best describes the characteristic lesion of the Kaposi sarcoma? I told you that it has been asked previously. So you have to Okay, sorry for the network glitch, guys. So this is the last question, and I told you that they had asked it a couple of times. A 35-year-old male presents with the lesion which is shown below in the axillary region. So the patient is also reporting that he reports that a similar rash is occurring at the same time. Just a minute. Similar rash is occurring at the same time every time when he takes a cotrimoxazole drug. Okay, everyone has already come up with the answer. So it is fixed drug eruption. Why? Because it is coming at the same site. So if they had asked the question previously, they can probably ask again as well. So look for the same site, look for the particular drug which is causing this symptom. So that's where we end the session, and I hope it was productive enough. Remember that in RR sessions we can't go into the depth of the subject, and if you really want to have a depth, you should rather it's this much is enough for FMG, I would say. So I wish you all the very best for your exams. Hope you liked your the session. And just my advice is revise this content one more time right after the class. Maybe if it is late for you today, the first thing in the morning tomorrow, just revise this session, and then a day before exam. That would be enough. You just have to quickly go through the PDF. Okay, easy questions are asked in the dermatology. So all the very best. Take care. Good night.